that I'm going to run through rather quickly because we have multiple guest speakers and I really want to allow them the opportunity to be able to share all the work they've been doing. So back in March, we started an initiative with SAMHSA. It was our Familiar Faces Learning Collaborative. And we've had 4 technical assistance meetings, multiple other meetings outside of that with Stacy, Camden Coalition, Johnson County. And so what we have on here is I just wanted to show the reminder of what we're doing with our Familiar Faces initiative. And that's we have the case consultation, we have the learning collaborative, and then we have the steering committee. So what you're going to see today is all the culmination of all of the work and then the recommendations that are coming from that. So this steering committee is going to continue to convene. And if you look on page 2, the Learning Collaborative put together a strategic plan. And there are 3 priorities within that plan. And each one of our presenters today will be sharing some information around the priority that they worked on. So we have Stacy Behringer here. She's going to be presenting on priority 1, which is developing a clear and consistent definition of frequent system users across agency systems. We have Mark right here. Mark, you're on a very large screen. And he's going to be presenting on priority 2, developing consensus around legal and feasible pathways to share information across behavioral health and criminal justice agencies. And then for 3, we have Casey with Ascend, but everybody in here probably knows that she's going to be talking about some of the work we've been doing for a dashboard. So we broke this down as a group into our priorities and some of our key objectives. And we've been able to, at this time, gather different points of views on how to define frequent system users. And that was actually work conducted by Stacy. We were able to determine our technical assistance needs and meet with Camden Coalition. And then we've also been able to meet with Johnson County to learn more about My Resource Connection. And we're continuing to meet with key stakeholders to discuss cases, data sources. Next steps, we need to finalize the analysis of our interviews. And one of the other things we really want to do is be able to do some more exploratory work with Casey and the Ascend team, kind of work backwards because we have information from the interviews on how we'd like to define familiar faces, but we need to make sure that that matches up with the data because we might want to define it one way, but if our data says something different, we need to be able to do that. We also want to continue to search across the state for other organizations who have done this and who have done this well. Pull all the documentation into an easily accessible location, and we would like to create uniformity in our MOUs and our ROIs. And for priority 3, we still need to analyze local data and create a dashboard. So on today's agenda, we have Stacy Behringer with Neomed. She will be reviewing priority 1. She is the assistant professor with Northeast Ohio Medical University. She has a PhD in social welfare from the University of Pennsylvania. Prior to her work with Neomed, she was an assistant professor at New York University's Silver School of Social Work. Her areas of expertise include reentry from jail and prison for those individuals with mental illness. She addresses the social structural production of recidivism risk, and Stacy's work again aligns with priority 1. So I want to thank Stacy for traveling here yesterday to be here with us today. So without further ado, Stacy Behringer.
Hi, good morning, everybody. Good morning. Thank you so much for inviting me to be part of this project and for participating in the interviews. I do research with sort of hidden populations and hard to engage folks. So it was such a treat that we just sent out a few emails and people signed up for interviews. So I really appreciate that. So I conducted 17 interviews each in about a month's worth of time from 17 different organizations. I talked to 18 people across behavioral health, the criminal legal system, supportive services, healthcare, and housing and homelessness. And I'm going to talk, what I'm sharing today are somewhat preliminary findings. Since I just finished an interview a few weeks ago, I am diving into the data, but I have some tidbits to share with you all today. So one of the things I asked you all about was the scope of this project. And as you can see from this graph, that predominantly the consensus was around this being a county initiative. There were a few folks who felt like maybe it should be a little bit more focused to the regional greater Akron area, just with concerns about collaboration, that it might be better to focus a little more until we have the collaborations down really well, and then we could expand the scope. Whereas there were a few folks at the other end who felt like perhaps this should be more a regional project, because if we recognize the group of folks that we're looking at, they are transient, right? And they don't stay necessarily within Montgomery County themselves. And so folks who are working outside of the city had concerns about people crossing back and forth between Montgomery County and other counties. So I asked folks to share about agency familiar faces. Do folks keep track of that? Do they know who those folks are within their own agency or system? And what I found was some places have a working definition for high utilizers within their own system. Most, but not all, could produce a list of high utilizers within their agency. And folks are employing a variety of practices to try to address this population within their own agency. Then I asked you all about what you think, how should we define this population within Montgomery County? And what was really interesting is that some folks were like, oh, this is someone we all know and see, or someone who has multiple touches across multiple providers, but isn't really connected to someone. Those were kind of the sentiments that were shared. So there was a range of perspectives around high utilizers, and I think that mostly stemmed from what sector folks were in. So folks who are on the crisis end of services, crisis calls, police, law enforcement, things of that nature. We're seeing folks who are calling multiple times a day, or weeks. And so for them, how to define contacts is a little different than folks who are serving people in inpatient or even the jails or in outpatient, right? So we have somewhat a range of perspectives. But the general feeling was folks should have contacts with at least 2, if not 3 or more entities in the community to sort of elevate them to that place of being a high utilizer. And once again, this time period ranged from 1 month to 6 months to years, like the amount of time that we should count the contacts in to elevate someone. And once again, I think that's a construct of people's perspectives from their own work with this population. The most sort of commonly sort of identified entities that people perceive that folks with falling into this category are the police, emergency rooms, homelessness, housing categories. There's some concern that folks have a mental health diagnosis, but also that substance use and misuse is part of this population as well. There are also concerns about non-adherence. And I want to just make a point. I'm using the term non-adherence as opposed to non-compliant, because there's kind of qualitative differences between those. People who are non-compliant can fall under the non-adherent group. So those are folks who are saying, I don't want this medication, I don't want to come to your agency, who are making the decision not to do that. But folks who fall into that non-adherent category include folks who might have trouble filling a prescription or remembering to take their medications or intend to go to their appointment, but they have a conflict. They need to see their probation officer at the same time, things of that nature. So folks who probably need a little bit more help and assistance to actually show up and engage in their treatment. And then homelessness was another factor that was cited amongst this population. So I'm going to skip this table for now and go to this slide. And so these are what I'm pulling, hearing from you all that should be included in the defining characteristics for familiar faces in the county. So once again, this concept of contact. Which entities are people having contact with and how many contacts? So we all need to really think about that. And then once again, this time period, how much amount of time do we want to use as a benchmark? Is it over several months? Is it a longer period of time? Once again, I think the time period helps us think about trying to differentiate between that chronic user versus the episodic user, right? Episodic is somebody who hopefully is in crisis for a short amount of time, but is able to avail themselves of the right services and supports and get out of crisis fairly soon. Whereas I think the folks that we're talking about for this Familiar Faces project fall into that more chronic category, who over a longer period of time continue to have multiple touches with multiple entities. Cost was something else that many folks brought up as what we should consider, right? My understanding of why this project came together is because you all want to utilize your resources more efficiently. And if you have folks who are knocking at multiple doors multiple times, you're not being so efficient. And so cost is an important thing to consider. I think that might be difficult in some instances to really attach costs with contacts. Some agencies probably could produce that information. Some agencies, it might be a little bit harder to do so. Diagnosis. Like I said, folks mentioned folks with serious mental illnesses, serious and persistent mental illnesses, substance and co-occurring substance use disorder. There's also some concern that folks are seeing a rise in folks who have developmental disabilities coming in contact with these services. I'm not sure how that all factors into this project here, but it's something that folks expressed a concern about. And then this category that I'm calling social needs, which I heard a lot about. So things like housing, things like travel, transportation, also things like loneliness. The perception is that some of these folks who are high contact just don't have anybody in their lives who are concerned. They're not connected socially to other people and are kind of using crisis services as a way to sort of fill that need. Might be out of the purview of this group to actually focus on that, but that might be something down the line that needs to sort of come into thinking about. So now I'm going to go back to this table. So what I did is the entity list are the services or the type of services or type of entities that were mentioned during interviews. So these are all the specific types of things that people mentioned that they think the high utilizers have contact with. And then the second column is I group them by system, right? So into the criminal legal system. So that would include 911, law enforcement, the courts, things of that nature. And then healthcare, so EMS, emergency rooms, folks who are hospitalized, inpatient, and then behavioral health, right? So mental health and substance use service providers, housing and homelessness, and sort of just this broad social services. So if we're thinking systemically, we want to capture people who have touched 2, 3, or all 4 of these systems. That's one way to think about it. So it could be, so if we're talking about the criminal legal system, it could be touches with law enforcement, it could be touches with 911, things of that nature. And so we could think about it systemically, or we could think about it in what I'm calling sectors, right? So we have folks who are utilizing crisis services. We have folks who are maybe in ongoing care, and folks who are more sort of those acute treatment providers. So this is ways just conceptually is like, how do we want to slice the pie? Or do we just want to talk about specific entities and providers that folks have touches with? And then on the next page is I went to the NACO website for Familiar Faces, and they have a list of how other counties have defined familiar faces. So I thought it'd be helpful for us to take a quick look at those. So in Sonoma County, a high utilizer is a person whose combined utilization across systems, so physical health, behavioral health, criminal justice, housing and homelessness, and human services, is in the top 1% in a given year. So they took a systems approach, right? They defined these systems, they defined the entities within that system, and then they just took a statistical approach to that, right? So whoever falls into that top 1%, those are going to fall and rise to our familiar faces category. Whereas City of Long Beach took a more discrete approach. Individuals with 3 or more arrests in the prior 18 months, and individuals with 2 arrests in the prior 18 months who also met one of the following criteria. nonviolent crime arrest identified by the police department as transient, or one substance abuse charge in the past 18 months. So their definition seems to be really driven by law enforcement contact, right? So that for them is what rose to the top as far as the population we need to address. Johnson County, you guys met with them, 6 or more bookings in a 2-year period. So once again, bookings into the jail. Wisconsin, same thing. Franklin County, Ohio, must have serious and persistent mental illness and 5 or more jail or law enforcement or EMS contacts in the past 12 months. So they're putting their diagnosis up front and center. We're saying this is the group of folks that we are particularly interested in. They have to have this diagnosis. There might be other folks who are having this amount of contact, but if they don't have that diagnosis, that's not the folks that we're interested in. 3 incarcerations in 1 year, and 1 access to mental health emergency room or primary care in Oregon. And Dane County is also law enforcement. So you can see a lot of these are using arrests or law enforcement or bookings into the jail as the way to approach this. Now, I would say there are 2 things that should probably drive your decision-making around this. So one, your decision-making should be driven by your goals. So why did this group come together in the first place, right? Is it to create a comprehensive safety net system, to decrease contacts with multiple agencies? Is it to decrease criminal legal involvement with folks with serious mental illness? Depending on what the priority of this group is, I think would drive how you would want to approach defining this in a different way, right? How you define it should match the goals of the group. And then the other thing, which I think Kimberly alluded to earlier, I think the data is also going to drive the decision making. I know you guys are working on getting a data dashboard together and trying to join together some of these disparate data sets. And once you do that, it will give you some insight into who are these folks? Is it primarily folks who are having multiple contacts with law enforcement and the jail? And maybe we should do a law enforcement criminal legal system driven definition. Or is it folks who are showing up more in the emergency rooms or in housing and homelessness services? And then maybe you do a more systemic definition and approach to this. And then the last thing I just wanted to talk about a little bit, because this really came up, system and service gaps. So I think folks generally felt like we have enough services, we have mostly the right kinds of services in our community. That's not the problem per se. The problem seems to be more of communication and connection. And communication being that different service providers are communicating with each other about cases, but it's also on a more macro level that just within the community, we have good communication going on about how to access services, about what services are out there. I know you all are standing up some new crisis services. Some folks express some confusion about, I'm not sure which number to call right now, or when it's appropriate to use this service or that services. And that's part of developing and growing. But there also has to be a plan to have a good communication around that. There's also, so the connection piece too is like, a lot of folks are like, well, I can make referrals, but that doesn't mean the person's going to show up to that appointment. And there seems to be some good use of peer workers, community health workers, and navigators and case management who do some of that function, but it doesn't seem like there is enough of it in the community. And perhaps with these folks who are falling into this familiar faces category, maybe it's not creating a whole brand new program, but at least assuring that there are warm handoffs, that folks are actually getting help with some of those social needs like transportation and reminders for appointments and things of that nature. But it's also connection within the larger community as far as, are we all working on this issue together? Are we rowing in the same direction, if you will? And communication, like some folks are like, our community's good. There's lots of agencies who are going out for grants, trying to bring more evidence-based practices into our community, and that's great. But maybe it should be done in a more coordinated way, so that we're informed all together about what the gaps in the system are and what this particular thing is going to do to fill in the gaps. Housing. So there's some supportive housing, and that seems to be utilized well. I think there's more coming down, but folks really talked about needing housing more with more support and services than supportive housing. That we have some folks who need more supervision, who need to be in some sort of residential placement that we don't currently have. So that was the one housing gap that was identified. And then within behavioral health, there's a perception that there are waiting lists to get appointments and to see psychiatrists. And that sort of creates, when you're working with this population, who you need to act, right, when you got their attention and got them engaged, it really then interferes with having to wait a few months before you can actually get them into seeing a provider. So that's what I have to present. Once again, these are somewhat preliminary. I'm going to continue diving into the data and write up a report to share with Kimberly and you all, but I am happy to answer any questions right now that you all have.
I got one.
Sure.
So what happens with this data? Do you, I mean, is it you that does the recommendations or what do we do with it?
With these so I'm just focused on the interviews, right? So I'm going to compile what everybody said, write up sort of the preferences, and then make some recommendations about approaches, which I've kind of done here in this talk. But like I said, I haven't spent as much time with the data as I want to. So I'm going to do that more over the next few weeks.
All right, thanks.
Yeah.
Do you feel like of the 17 different organizations and entities that you interviewed, that was a full scope and realistic perspective of our community, or were there gaps?
Well, for me, the biggest gap was consumers
Okay.
or folks who are actually utilizing the services. I personally would really like to hear from them and their perspective, because my guess is they might highlight gaps in the system or barriers that we all aren't necessarily focused on. So I've reached out to some folks to see if we can maybe get a few of those interviews. I'd like to include that perspective. So for me, that was the one glaring one. I have to think more about anything else. I mean, it seemed like I got pretty good range of perspective.
When you're talking data, is it just something like this? You're gonna organize it by category and then get a sense from the group as to how they responded? Is that what your data means, data points mean?
Yes, and I will also include quotes from folks, so you can sort of, right, so I did interviews, right? So I did not do a survey. I just talked to folks, they gave me their perspective. And so, so the data, I'll make some claims, right? Like this Venn diagram, but I would give them some quotes about supporting, which is the supporting data around what folks were specifically saying about them. Yeah, it won't be numbers per se. I could do that if that's what you all are interested in.
Just asking.
Yep. So just the feedback, does that approach, like thinking about these different areas? I would like to get feedback, from the group, like, do these areas seem like the areas of concern? I guess I would put this all back to you, or do you all feel like there are gaps here? Thinking about contact, thinking about the time period, diagnostically, cost, the social needs, or are there things like here we shouldn't be looking at, or other things that we should be including?
And contact is the number of contacts that they've had with the system?
Number of contacts and kind of like with whom, right?
Okay.
Yeah.
I do have a question. So as you're looking at the defining aspects, I think some of these are symptoms of problems. So as you're going through this, and as you said, kind of making some of the recommendations, maybe even building upon what you've talked about today, like for like time period, I mean, we can talk about like workforce shortage and things like that. So is that something that you'll be addressing or something we kind of need to think about collectively as a group?
Yeah, that is a great example. I mean, that is another thing that folks said is a problem in the community. I didn't put it in because it didn't come up nearly as much as some of the others, but I mean, yeah, that's a huge symptom-wide issue and is probably contributing to some of this also. Yeah. But I don't know how that, that doesn't fit in the definition per se, but it is definitely a system-wide thing that needs to be addressed. And you guys aren't alone. I talk to communities all over the state. It is every place. Okay.
Awesome. Well, I
Thank
want to
you.
thank Stacy for joining us. So as we're when we receive the final report, I'll make sure that's sent to all of you to review. I do want to bring Jen Hochdorfer up here just for 2 or 3 minutes. So when we think about our familiar faces steering committee, we're looking at not only how we define familiar faces, how we're going to create the dashboard, but I always like to bring it back to the people. So if you just want to pop up here and just share a little bit about some of the case consultations that we've been doing and humanizing it, bringing it back to the people.
Sure. So since November, we have been having case consultations, and we have really seen the number of community partners really increasing in the referral base. We are holding weekly community meetings at this point in time with some of our individuals who are being identified as familiar faces. And while I can think of some individual successes, and I'll highlight, I think too, I think for me, what I'm seeing as one of the biggest successes is the collaboration that we're having with multiple partners in our community who probably wouldn't normally have that type of interaction and collaboration with each other. So 2 of the more recent ones that I can see as some big successes is, I think we often know that some of our youth in our system kind of get lost in that transition from the point where they're 17 years and 11 months and 29 days until they're magically 18 years old. And I think all too often, some of our youth kind of get lost in that transition process. And so we've recently been working and had a number of familiar faces meetings with a youth who is 18 years old and has had kind of a rocky transition from childhood to magically becoming an adult, where he's supposed to know everything and be able to make all those decisions and everything for himself. And so as Children's Services is in the process of transitioning out of custody and emancipating this youth, we've had a number of familiar faces meetings that has involved a number of our housing providers, our mental health providers, some of our hospital systems, because we know this youth is going to be a high utilizer of some of our hospital systems. And so I can say one of the biggest things for this youth is we're currently linking him with a mental health provider. We're identifying housing options for this youth. The Children's Services caseworker is doing some planned transition kind of visits with the caseworker at the mental health agency to really try to make this transition from the youth world into adulthood as streamlined and simple for this youth as possible. So I see that as a major success, where we're involving a number of systems that wouldn't traditionally be able to talk to each other. And we all know it is difficult sometimes for youth to transition into the adult system. And then the other success that I've seen recently is an individual who has had a lot of involvement with our homeless system, both in street outreach, the shelter, one of the Safe Haven program, long history of services at multiple mental health agencies, a lot of involvement with the criminal justice system. This individual's been to Summit on at least one occasion. And what I've seen recently is there were varying opinions between probation officers and the mental health providers and the housing system on what would be most beneficial to wrap services around this young lady. And I really believe that through one of our more recent Familiar Faces meetings, it allowed probation, it allowed the homeless system, it allowed the mental health provider to really talk with each other about what each entity was seeing with this young lady, and to then really develop a good plan of care for her to get her into some dual diagnosis treatment, and then to identify a long-term plan for housing. And I think that is, her housing will be a key for her success. But I think each person had something different that they thought was best. And the Familiar Faces meeting really brought everybody together to talk about those varying viewpoints and to identify a plan of action. So I think those are two of the success stories that I can think of recently.
Thanks, Jen. All right, yeah, just like to bring it back around to all the good work that the community is doing. We have Mark. Can you hear us, Mark? Say hello.
Hello, everybody. Can you hear
Hi.
me?
Say your last name. I can never say it correctly.
Sure, it's Humawiki.
Oh, I always say Humawiki. Can we
Turn
turn
up the volume, Mark.
What'd you say?
Can we turn up the volume?
Yeah.
Thank you.
Yes, we're gonna turn up the volume and I'm gonna do your intro.
Okay, sounds good.
Humawiki. He's a graduate of Yale College and Yale Law School, and before his work in government, he spent 6 years as an employment attorney for Legal Aid Society and also in a private practice. Mark is currently the Camden Coalition's legal counsel and leads local, state, and national advocacy efforts. Mark's going to be presenting on the work that he's been doing within our learning collaborative over the past month or so. So without further ado, take it away.
Great, and I'm gonna go ahead and share a set of slides here. Can you all see them?
Yes.
Okay, and I need to press like start, right? Let's see. From beginning. Okay. So, well, thanks for having me. It's been, my colleague Jason Torrey is on vacation this week, so he's sorry he can't be with us, but the two of us have been working with Kimberly and the whole group really for a couple of months now. And Stacy and I have never met and we did not coordinate, but you're going to see there's a lot of consistency between our recommendations. So hopefully that makes it easier for you all as you move towards implementation. So the goal for our engagement with you all was to support around building a collective vision and commitment to cross-sector data exchange and integration. So we started our work way back in the spring with a half-day site visit as part of a learning collaborative. I think I met many of you there. We've had sort of a discovery process with Kimberly and with Ascend, sort of understand where you are and where you're hoping to go. We planned a 2-hour meeting on the 7th of August that we ended up having, and then we've done some work since then to really prepare a final report. So there's a written report that we'll be putting together, and there are these slides in today's presentation. So during that 2-hour meeting, we spent some time talking about what sort of data we would want ultimately to be brought together as part of work. We talked about the difference between sort of de-identified data that can be used for policy and planning and evaluation purposes, and then identified data that's used for operational purposes and providing services. You might actually have two different structures. At the Camden Coalition, we've been on this data journey for close to 10 years, and we have two very different infrastructures to support those different uses. But the other thing that we learned throughout our process is this is long-term work. And so we'll have some recommendations about how to go about in the early stages, thinking both short-term and long-term, but recognize that as I show you both data sources and use cases, you're not going to do it all at once. So it's about prioritizing, it's about looking at opportunities where people feel the most comfortable, where they feel the most value, where they feel like the legal structure is easiest to apply. So here's some potential data sources. We've got hospital data from the Greater Dayton Hospital Association. We've got Justice Web. We've got claims data that's paid by the county board for behavioral health services. We've got Medicaid data, similar types of services, but being paid under the Medicaid program. There's an interest in medication data, treatment adherence, service dates, homelessness data, data from within a jail partnership, fire and EMS data, Narcan administration data, and other treatment data. So wide range of data sources that could potentially be brought to bear, again, depending on the use case, depending on the structure. Some may be better than others, but it was nice to see sort of a wide range recognition of the value that different data sets could bring, particularly when combined. So here are some of the high priorities for use cases. First is, like I said, sort of from a de-identified standpoint, where you can bring together data about individual level data, connect them at the individual level, but then show them back to people without identifying people. It's much less risky from a data security and from a privacy standpoint. And so this is relatively easy to accomplish. So thinking about how the data helps this group, which is, I should have said at the outset, very impressive collection from the Montgomery County area. Y'all are doing a lot. I'm trying to do a lot at once, which is both admirable and can be challenging. So just give you the congratulations on that, but also the reminder that this is for the long term. You may need to pace things, and you may need to sort of be strategic about what you do first, second, and third, and not try to do it all at once. But I think this is the kind of work that you're trying to accomplish through this learning collaborative, through your steering committee, through your behavioral health steering committee, is exactly the right kind of work for right now. And we're seeing other communities around the country that are trying to do similar things and getting a lot of value from the sort of cross-sector collaboration. And data can, in our own experience, can really help solidify the commitment to working together, because you start to see the connections in the people that you're serving quantified and really made real through the data. So Stacy had some great reflections from you all that there's a sense of the people that you all serve jointly. But I think it takes on a new sense of concreteness when you actually see that in the data and the numbers. So clearly better strategic alignment, funding, communication, partnership, from really having a sense of your common issue that you're working on, using data to identify common elements to be able to move upstream. I think this is often a sentiment of like, we don't want to just focus on people who are familiar faces and dealing in the crisis and managing the crisis, but actually want to think about reshaping our systems to be able to be more preventative. And then just understanding and quantifying the overlap and movement between the systems of care in our community. And I'm going to show some examples of how we did that in Camden that I think is very consistent with what Stacy found, and hopefully very doable with your partnership with Ascend. There's also an interest in individual services. So being able to have access to data when you've got a real person in front of you, whether you're on the criminal justice side and you're just trying to decide whether to send the person to jail or to divert them to a program, whether you're in a clinic or the hospital emergency room and you want to understand who else is working with this person, what their treatment plans are, what recent services they may have gotten in other settings. So being able to provide treatment programs, prepare those programs, share them across agencies, understanding what other actors have done in managing the same person, being able to make decisions based on their participation in other programs, and being able to look at histories when people are going between and amongst different programs to have a more complete picture to inform treatment approaches. There's also definitely mentioned the being able to protect staff by identifying those who have a risk of violence. And number 7 is something that we added, wasn't named necessarily, but is something that we certainly have seen, which is once you have data flows like this, particularly the hospital data that's real time, and if you can get real time criminal justice data, you're able to create those sort of real time alerts that allow the different institutional partners to be aware of when someone's hitting another system and to be able to react proactively when the person's either in custody or in treatment, as opposed to looking at this weeks or months later. There's also some population management strategies that can be sort of fueled through this cross-sector data, being able to create a list of familiar faces for purposes of doing some case consultation, as was just sort of explained, and maybe even quality improvement. This is something we did in Camden, where we really did sort of deep dives and collaboration with the top 10 sort of frequent users between the two systems. We continue to learn a lot more about what was needed and what worked, and really informed our strategies going forward. You can use data to create frequent flyer or high risk flags. Again, as you start to work with the legal counsel around what sort of information is shareable and not shareable, there are ways of sort of shielding some more sensitive information while still being able to indicate that somebody is in need of a certain level of service. And then producing panel reports. This really goes back to that question of alerts. So you can have people can understand who within their current treatment panel is a familiar face for multiple systems, and then also can get alerts when those people have different triggers within as defined by your business rules. So those are some of the things that you all talked about as wanting to see from the data. Again, recognizing that this is not going to be created in 6 months, and that you're going to have to start small with smaller data sets, maybe 1 or 2 use cases, and over time build the infrastructure, capacity, and trust with one another to be able to share the data for broader purposes. But ultimately, our expectation just would be that you can do this. You can build a data infrastructure that allows for significant data sharing to do the policy, the planning, the evaluation, as well as individual level patient and client care that can really be improved by bringing together knowledge and information about people from across the whole continuum of care. So here are some of our recommendations based on our work in Camden, based on working with communities around the country. One is to start with exploratory analysis. And I think what you heard from Stacy was there are a lot of ideas, but they weren't necessarily data informed. And so when you start to take the ideas about number of contacts, time period, cost, diagnosis, social needs, and you pair that with the data sets, and you can actually start to look at the data based on those different variables, you'll start to see what does our community look like? How does it break out? If you use that Long Beach 1%, or you decide that we're going to just do some cluster analysis and see, what sort of groups people fall into. We did that. I'm going to show you a couple of slides from our work in Camden from almost 7 or 8 years ago. And you'll see, sort of, I think we learned a lot from doing that exploratory analysis before we ever decided to build a dashboard or set parameters for a program. We really needed to understand the underlying issues much better. I think second is about balancing short-term wins with long-term vision. You can't do everything at once, but you need to be able to show value to your stakeholders to keep people going. And so This is true of any sort of big change management project. But I think you have real opportunities given the partners at the table and Ascend to do some really good work that will provide value to everyone and keep this going and actually accelerate your work in this space. Again, provide value for all stakeholders. This can't just be about one stakeholder. Everybody has to see some value to themselves, to their clients in these projects, even if they're not necessarily the first priority, for the first project, that over the long haul, they can see how this is going to make their work better, more efficient, more effective. I think ultimately you want to build a data governance structure. Everybody has responsibility for their programmatic data. They have lawyers and others who are going to make sure that they're complying with regulations and legal requirements. And these decisions to how to share data and how to structure that need to have the voice of sort of all relevant stakeholders. We've had various committees. We have our Health Information Exchange, and we have a governance committee there that's been very functional for 10 years. It's worked on a consensus basis. If anyone's not comfortable with the data use, we don't move it forward. That sometimes can slow things down, but has really proven the most effective in terms of building trust and everyone feeling like they're comfortable moving things forward. And we've added a lot of data sets and a lot of data uses in the last 10 years. So that's critical. There's a suggestion here around AISP. That's the Actionable Intelligence for Social Policy. It's a center out of the University of Pennsylvania that I've done a lot of work with, that functions as sort of a national expert and convener of integrated data systems. They have sites around the country, and we've been a site. They provide technical assistance. They have an annual conference. They have a lot of resources on their website. I helped author a report on providing sort of creating the legal agreements for integrated data sharing. They have a really nice manual on data governance that I linked to in the report. So a lot of resources there and really great people that can provide additional support. And then also consistent with Stacy, I think adding people with lived experience to help oversee the program, but also to help interpret the data. As she mentioned, they bring a different perspective. They bring their own lived experience. There may be things that you aren't thinking about that they highlight. We do a lot of work in our work locally in Camden and throughout the country to really promote the inclusion of people with lived experience in these types of projects. It's not easy necessarily. You can't just say, okay, well, let's just put one person on who's got lived experience and then everything else we'll just do as we have done. It takes thoughtfulness. It takes translation of acronyms. It takes thinking about the time that you meet and the resources they need to be able to fully participate, compensation and other things. Again, I think the value of doing it is well worth the cost, and particularly when you're talking about vulnerable populations like this, making sure that that your community understands what you're doing and understands why you're doing it, and the value is really important to building strong trust with the community that you're serving. So I wanted to just give you a quick peek at some exploratory analysis, because this term can just seem sort of vague to people who aren't data folks, which I include myself in that group. But these are some of the sort of data visualizations that we did in Camden back in, I think, like 2016. So taking in the pink hospital data, we had 3 different health systems. Over 5 years, we had a total of 374,000 individual patients that received services from those systems. And then in the blue, people that had encounters with the police. Here we're looking at arrest data. And then in the green, we had overdose data. So 3 different data sets, sort of a Venn diagram, because we had it at the individual level. You can see where there is the overlap is the people that you're most interested in, the familiar faces. And you can start to see these breakdowns by percentages. Most people hitting the hospital have no criminal justice involvement, have not overdosed. Those are not the people you're worried about. You're worried about a much smaller group of people. Here is some further analysis based on distribution. So, we talked about frequency of contact. So here's by the numbers, people that had 1 police encounter. That's most people. 2 to 3, that's a smaller subset. 4 to 5. So, as you move across, you get much smaller N sizes, but the number of contacts is much higher. So the percentage of police resources that they're taking up are higher. And these are the familiar faces that you want us to look at. So then you can break it down because of the information within the data sets about whether or not it's violent crime or whether it's a drug-related crime. You can look at whether or not they've had a hospital encounter. Interesting to see that as you move to the right, the more jail or the more criminal justice involvement, people had more encounters with the hospital as well. So here's another one with sort of looking at diagnosis codes and other information within the data sets to look at prevalence of substance abuse, mental health, and homelessness. Not surprising, those that had more frequent visits in both systems had much higher rates of substance abuse, mental health, and homelessness. So this sort of analysis helps you sort of hone in on what are the key issues that you want to be focused on. Obviously, these aren't going to come as a surprise to you, but the ability to quantify and then to go into sort of an individual, and you can de-identify or anonymize them, but just look at all the different places over a time period where they're having encounters. So this is an individual. You can see along the left side, I know it's really faint and small, but you'll have copies of these later that you can look at. The different diagnoses from hospital involvement, and then on the bottom, different types of crime from the criminal justice data. And you can see this is over a period of time. You also can see whether or not they were living in a homeless shelter or residential, or they were on the street, all of these different encounters. And it really gives you a sense of times when people are seeing the different person and how do we respond? How do we think about getting them into treatment? So on and so forth. So I'll stop there. There's more of that analysis from Camden that will be in the written report that I'm sharing with Kimberly after this meeting, that you all can look at. And we are around and happy to provide further advice or do additional work with you all if there's ever a need. But really want to wish you the best of luck on this work, because it is really important work that you're doing. So happy to take questions. I'm not sure how much time we have, Kimberly. I'm sure I went over by a minute or two.
You're okay. Thank you, Mark. Does anybody have any questions for Mark?
I just had a general question, like, I think it was 17,000 arrests or 30,000, whatever the number was. What pool are you, what is that from? Is that countywide? Is that specific law enforcement agencies? How are you pulling that information? Just for an example.
So thank you. That data was countywide from the Camden County Police Department, and then from the Camden County Jail. So that's where that data came from.
Because there would be other, multiple law enforcement jurisdictions within that maybe you're not pulling from?
That is correct. And I am not going to be knowledgeable enough to be able to dig into that. But we do have a county-based police department for the city of Camden. So it was including the major urban area. And that was probably the locus of interest for the group, was really on the crimes that were happening in Camden City. So we did get all of that information, but yes, certainly there were town police that we may not have gotten the information that so there may be things missing for sure.
Yeah, we've got the same setup here. All right, thanks for that. We're on the right track, I guess.
Yeah.
Any other questions? Well, thank you, Mark. We appreciate it. Are you going to stay on to listen to the rest?
Sure.
Okay. All right. So Tina's going to be handing out the presentation from Casey. Casey has requested that I not read a bio on her. So you all know Casey Smith. So
Stay here.
yes, she is addressing priority 3 from our strategic plan.
So I'll go ahead and get started. I know Tina's passing out the slides. The slides will be helpful, especially as I get into the current dashboard functionality, because you'll be able to see what I'm talking about. But I'll just quickly start with a background on Ascend, myself, so that those of you in the room who haven't heard of us, you can kind of understand how we come into play here. I'm Casey Smith. I'm a senior accountant project manager at Ascend. Prior to being with Ascend, I worked for public health data in Montgomery County here for about 8 years. So my background is in public health and behavioral health related work. Ascend Innovations is a community health data and technology company. We're based here in Dayton, Ohio, and we were formed out of a unique collaboration between the Greater Dayton Area Hospital Association and the 3 major hospital networks, Premier, Kettering, and Children's. So have a unique ownership structure in that we've got that relationship with Children's, with Kadaha and the hospitals. On the third slide, I believe, it just goes over the title of that slide is Our Expertise. Just want to highlight that our team is comprised of 3 disciplines. We've got data scientists, user experience folks, and software engineering. Those are really our core capabilities. So what I want to highlight here is the user experience bucket. Before we go into building any data or technology solution, we're first going to go in, and to some of Mark's point around exploratory analysis, we're going to go in and understand what the root cause of the problem is, to make sure that whatever data or technology solution is being built is best fit for the problem at hand, and that we're understanding the various users and perspectives before immediately jumping to a solution. And then the rest of our team is comprised of data scientists and software engineers who make all the magic happen in the back end. If you go to the next slide, again, I just touched on this, but really our process when we're working on building any sort of data or technology solution is that we're first going to take time to discover and really understand those problems at hand. So much of the learning today is very helpful, especially as we think about how this Familiar Faces dashboard could be enhanced in the future. And so if you go to the next slide, Ascend has strong partnerships across the state of Ohio. In addition to working with the Montgomery County ADAMHS board, we are working with, I believe it's 13 additional boards at this point. So we have coverage across 30 counties now, I believe, across the state of Ohio, working with those recovery boards as they look to really understand their knowledge of community needs. So helping them bring together those disparate data sets as it relates to accessing hospital data, treatment data, law enforcement, jail bookings, coroners data, really to help them make those data informed decisions and more effectively allocate resources and make service decisions. If you go to the next page, this is really where we talk about data that we have access to and that we work with our community partners to look at when we're making decisions around what data sources will feed into these data-driven products and solutions. So we have developed relationships with the state HIEs by way of our relationships with the Hospital Association. There's 2 state HIEs currently, the Health Collaborative, which is in the Cincinnati area, and CliniSync. Health Collaborative is going away and transitioning to CliniSync. So there will be 1 HIE here very soon. But we've developed relationships with the state HIE so that when we go into these communities, we can have conversations with those boards and then hospitals locally to get those data agreements in place so that we can use that HIE data for that specific community. We house all the data within a secure HIPAA compliant, Part 2 compliant cloud-based environment, which is an important note, given the sensitivity of the data that would be coming into a dashboard. And so there's 3 buckets of data that we typically talk about. The first being that health information exchange data. HIE data is those hospital data feeds that are updated daily. We have access to both hospital and physician encounter data through that. Additionally, we have information on demographics. The type of encounter was it emergency department, inpatient, outpatient, admit and discharge dates, some basic payer info. It's not always the most accurate. Chief complaint information, and then diagnostic and comorbidity information for those hospital encounters. In the treatment data bucket, currently the main source of treatment data we have would be any GOSH patient claims that were paid for by the recovery board. So that is a limitation in that we wouldn't have Medicaid paid service data or privately insured individuals in those treatment claims that would have been processed by other means. So again, our view of treatment data would be any of those GOSH patient claims that the board had paid for, as well as those Medicaid reverse extracts. And then in terms of the community data bucket, this is really where we look at the currently criminal justice related data, but conversations with the county and the HMIS system to look at long-term what potentially integrating homeless related and shelter data in an aggregate form to help make those service decisions. Other social determinant data sources could eventually feed into that, but primarily in the community data bucket in this point in time, we've looked at justice related data. And so if you go to the next page, it's the blue slide, it says enhance your data strategy. Just an overview of some of the data related projects that we have worked on with community health organizations. Two that are relevant to the conversation today. I'll quickly touch on crisis notifications. I know that was one of the things Mark brought up. We have a crisis notification infrastructure in place with the board, and they've had that in place for some time. But it is a secure mechanism to notify providers when an individual who is tied to their services has hit a hospital on a behavioral health encounter. We're making an attachment or unattachment identification based on cross-referencing that GOSH paid service data. So if that individual hasn't had a GOSH paid service by the board, then we're not going to be able to identify what provider they're tied to. So that person would be an unattached individual and would then be routed to one of the mobile crisis response teams locally for response. But that crisis notification infrastructure does exist and it's scalable so that we could look at other use cases for that. So just wanted to drop that after Mark had made that recommendation that infrastructure is in place with the board. And then the other piece that I'm going to spend a little bit of time walking you all through is the board's familiar faces dashboard. If you go to the next page, the familiar faces dashboard is the opportunity for the board to identify those individuals who are appearing in multiple systems for acute care, justice related encounters, and then any behavioral health related services that were paid for via GOSH. And so again, talked about the data sources. Lots of use cases. The board, please feel free to step in if I miss any, but forensic monitoring purposes, familiar faces, steering committee and case consultation work, this dashboard can be used for pre and post intervention analysis. Jen or Kim, any I missed that you want to touch on? Okay, but the dashboard, as you will see here in a minute, provides the board the ability to answer questions related to who needs treatment and support now, what systems are they currently interacting with, and then kind of retrospectively look at, did that individual receive the treatment and support services they needed? So if you go to the next page, I'm going to walk through each of the tabs within the dashboard. These are demo slides. This is dummy data, so this is not individually identifiable data. We just wanted to get some dummy data in there so that you all could see functionality of this dashboard the board has. So this page, the first page is a patient summary. So what I want to call attention to, and these filters will carry page to page, is the filters at the top. We have filters for the individual's first and last name. You can also type in the names for quicker search, zip codes, sex, the hospital name. The hospital name with the HL7 data currently is going to be at a network level. It's not the individual hospital level. So it would be Kettering or Premier. We do not have Dayton Children's data in there currently. You can filter by age. And then the three I want to call attention to are number of hospital visits, number of GOSH claims, and number of justice encounters. As you all work to make decisions around how we define familiar faces in Montgomery County, that's a place we could easily incorporate thresholds based on number of contacts, number of claims. So just something to consider. Currently, the patient panel that's built within this dashboard is built off of individuals who have had those GOSH claims. So for an individual to show up in the system, they have to have had that board paid service. to then see any of those justice encounters or hospital encounters. But again, easily incorporate thresholds if those decisions were made by the county and the partners at the table. And then you can see the table view at the bottom. If you don't add any name filters, zip code filters, this is going to be anyone who's included in that database. You can then filter, if you look in the middle there, number of GOSH claims, number of hospital visits, number of jail bookings, those column headers. There's a drop down where you can, or a little arrow where you can filter from most encounters to least or most claims to least. So you could look at those when we're talking about the conversation around familiar faces with the most encounters or the most claims in each of those systems. The dashboard in its current functionality could filter based on that. If you go to the next page, this will be the next tab down, looking at hospital and justice overlap. Currently, it would look at Montgomery County jail encounters by way of Justice Web, and then any of those distinct hospital encounters. Again, you can filter based on that individual's name if you want to look at a specific zip code, but really the benefit of the system is the ability to search at the individual level. And then the table view at the right would have the number of GOSH claims, hospital visits, and jail bookings for whomever that individual or filter that you had picked was. If you go to the next page, this is going to be some information on patient location. So this is really answering the where those individuals are accessing services. So if you filter by that individual, we'll be able to look at the hospitals and potentially the jail that that individual is interacting with. So this mapping ability is going to show where these folks are accessing services. If you go to the next tab, this is the patient report tab, and I would imagine probably the most used page. If you search that individual, you're going to see that individual's interactions across the 3 different systems that are currently incorporated into this dashboard. So you'll put the individual's name in, and then there's 3 tables at the bottom. You're going to see the Justice Web Montgomery County Jail encounter data. To the right there, you'll see their hospital data. So any hospital admissions, the hospital, the admit source, and then the diagnoses associated with that hospitalization. And then the bottom table there will be any GOSH paid services that had occurred for that individual, with who the provider was and what the diagnosis was, along with some cost data around what was billed specifically for that encounter. You go to the next page, this is going to be specific to the individual's hospital encounters. So again, if you search the individual in that top filter, you'll be able to see the number of encounters, which hospital system that individual is intersecting with, and then a comprehensive list at the bottom of those encounters and what the diagnoses and admit dates and times were associated with that individual. If you go to the next tab, which is the next page, this is going to be the hospital jail report, currently looking at Montgomery County jail bookings, the charges associated, the number of bookings over time. So you can see that by year, month, and day table at the bottom to see if there's any trends or patterns in that individual's intersections with the system. And then there to the right is going to be a kind of further blown out view of those charges and when those occurred with what agency. If you go to the next page, this is going to be specifically looking at the individual and their GOSH paid services by the board. So this will have the sum of bill amount over time. Maybe the board is wanting to look at how much they've spent on an individual in a calendar year. With those date filters at the top, you could change the dates to then filter down the sum of the bill amount on that individual. And then you've got the sum of the net amount for the individual. At the bottom there, the board has view into any claims and which providers those claims were associated with, how many claims per provider. And then there to the right, you'll see additional information on the individual and what procedures were billed for and paid for by the board. And then the last tab there, I don't have a page on. You'll see if you stay on that page, under that is a placeholder for overdose and suicide related data. We are working right now, we've got a data use agreement in place with the coroner's office. We're still working on data pipelines there, but can eventually look at integrating any coroner related data to overdose, death, and suicide. So that will eventually get incorporated, but just have a placeholder tab there until we get the pipeline of data finalized. With that, what questions do you have?
So is this And then for administrative use, can it be used, like, can you put the treatment team attached to this person within some sort of search and then say, okay, I need to reach out to this person for this?
So in terms of like which person at the agency the person is tied to, is that what you mean?
Yeah, you need look kind of like a key person, yeah.
Yeah, so it doesn't include that information now, not to say that it couldn't, it would just be a matter of getting the information from the provider, or if it was a case manager, getting that information incorporated.
Yeah, I will say, I think that would be possible to do with our GOSH system. My question though, and I don't know why I've never asked you this, is somebody like with the familiar faces, is like if somebody never has a GOSH paid claim, are they not entered in that? So if they're like Medicaid and have.
Correct. So we're building, the way it's currently being built is off of those GOSH paid services. So that's gonna be our baseline data source. And then if the individual has had that GOSH paid service through the board, then we would build and have the information on the hospital. And so definitely limitation. And that lack of access to Medicaid data, I'm sure not surprised to the board providers, is a huge gap. And that we aren't able to see if individuals are having those treatment services paid by Medicaid, we don't have access to that data. So we're not gonna be able to look at those matches. Yeah.
I'm not sure what stage or what the intention is at the SENS end, but as I understand it, I mean, you guys are getting our data and Excel sheets, and our data from the probate court civil commitments specifically are being filtered into Justice Web eventually. Is that going to show up here as far as your understanding, whether we would see civil commitment cases as well as the criminal charges?
So it could absolutely filter into this. I don't think that, there's no limitation. I'm software engineering and data science would probably kill me for saying that, but if we've got the data in Excel or CSV, we could easily fill it in and make the matches on the back end. I don't know if Sarah or Haley or anyone want to talk about kind of some of the recommendations related to the BH task force work, but I think the goal would be that we could feed as many additional data sources in beyond this baseline of what we have currently to make sure you all have a comprehensive view of all the systems that individual is touching, not just what we have currently.
So you're not married to it, I get it. So-
Oh, yeah, and we've worked with the board over the last 5 years to continue to make updates. We do user interviews with the board and their staff to understand how is it functioning currently, what updates or modifications would help their work. We actually changed the hospital data source in this last update. We originally used OHA data, which is the Ohio Hospital Association. It's a little more comprehensive in that there's payment amounts with that data. The problem is it lags roughly 90 days to a quarter. So that hospital data wasn't real time for the board. So by switching to the HIE data feed, that's more real time and is going to allow the board to see those near real time hospital interactions versus not having anything over the last 3 months. So we continue to go through edits and modifications to the dashboard to make sure it's meeting the needs of the board and their work.
In the event that the individual is not covered through the GOSH claims, will we still be able to go in through the hospital report to find individuals from the community that maybe fit some of these definitions and criteria, but they're not currently being covered by ADAMHS funding?
Yeah, I think it would just be a matter of probably data use agreements to make sure everybody was covered and buttoned up in terms of just making sure the data use agreements were in place with each of the parties who had access.
Does the hospital interchange fee come with payer information?
The HIE feed,
Yeah.
it does have a little bit, but I think Sarah may be able to talk to it. It's not very clean.
It is not a fully comprehensive payment source. So we couldn't rely on that fully for payment data.
Is that why we can, I mean, I think we all know that there's a certain Medicaid provider for which we have high costs and such. But is that the reason why? Is there some other barrier that we can get around?
I would have to look into that. I don't know what the connection would need to be in terms of. If
But
we're
I
just
understand
looking
what
at
you're saying, that can be
Medicaid,
muddy data initially until it's cleared
Yeah.
up.
if we could get to an agreement at ODM with MCO data for our region, that would be, I feel like that would give us the safest connectivity from a data perspective. And that would give us the 5 managed care organizations. But beyond that to try and then pull in the private pay sources.
I think leaning in on that.
Hey, Casey,
Yes.
are there going to be, how does this work? If, is it whoever gets into the system sees everything, or are you going to have permissions for other people to pull certain information?
So there will have to be permissions just based on the legal frameworks in place. I remember Mark, I think it may have been, I don't recall who talked about it, but that law enforcement unfortunately would have the least insight, and then your covered clinical providers would be able to see the most just based on HIPAA and 42 CFR guidance. So I think that's part of the work that we have to continue to dig into is who can see what, but permissions can easily be built into the system.
We also have a legal consult with Stacy Harper at 3:00 today. If you're not able to attend or didn't get the invite, let me know or email me questions you might have.
Can you de-identify the data, the HIPAA data, and put in a percentile range or something like that? That would be easy to understand for the people that don't have access to the real detailed information.
I'm sure we could.
So this is an operating system that the ADAMHS board is using currently, right?
Correct. I believe it's been, the board may know better than I believe it's been in place since some point 2018. And then over the course of the last 4 or 5 years, we've continued to modify and enhance the system to make sure it's meeting their needs and their work. So they also have a population dashboard, which is entirely de-identified aggregate data for more kind of service decision-making, grant writing purposes. But that population dashboard, you don't have the ability to search any individual level data. It's pooling all of that data together just to look at kind of trends across the community. Comparable filters, and that you could filter by zip code, race, but no identifiable information in that dashboard.
Casey, you may not know the answer to this, and that's fine, but I know you mentioned that law enforcement, and I'm assuming the jail would have the least access to information. So how would this be helpful to them? What can they see that is still helpful to them from their perspective on these people?
My answer is going to be determined. I think we've got some of those questions built in for Stacy this afternoon. Our team pulled some questions together to start to understand the permissions. Mark, do you have insight into what your law enforcement is able to currently see within your system?
So, I mean, I think you have to separate between identified and de-identified. So I think the law enforcement would have access to all the de-identified information just like anyone else. So, you know, the kinds of aggregate analysis or, you know, breakdown analysis you do, everyone would have access to. In terms of the real-time clinical information, I know our jail provider is on our health information exchange. So they have access to the same information that a primary care provider would have. But a police officer sort of on the streets would not, and does not have access to the health information exchange. I mean, often the conversation gets, once you get beyond what data we're sharing, it's what platform it sits in, because you want to make sure that the data is actionable and that people, you know, don't have to log on to another system and another screen. And so it's how do you bring that data into your systems in ways that can provide additional value. I'm not sure if law enforcement is getting additional clinical information. I don't think they are, outside of, like I said, the jail provider. But there was a lot of, because of what we found, there were a lot of new programmatic partnerships that started between our academic addiction provider and our jail. And so now there's really like a seamless transition of people from the street through the jail and back onto the street in terms of maintaining medically assisted treatment and other things that people even get put on buprenorphine inside the jail. So there was a lot of work that came out of this that wasn't individual focused, but was really more at that system level and develop new programs and partnerships. With consents, and consent gets more complicated when you're in a custodial, like law enforcement relationship, but there is the ability to share that information, but it's you don't need the same level or on the health side. So hopefully that's helpful.
Thank you. If it's helpful, kind of going off of that, this is super preliminary and I don't mean to like take us completely off course. I met with a company that does a lot of data management focused specifically on referrals. And it's like a referral system. And what I was asking them about yesterday was whether or not whoever refers could see the outcome of that, even if it is like substance use services or mental health services, just knowing that it's complicated to share that data. And so whether or not we even continue discussions with this company, just knowing that there is potential to be able to notify whoever the referring agency is, whether that's law enforcement or it could be a social worker, anybody, to show maybe not where they went, but whether or not they had a successful referral and if whether or not they've completed their treatment. So, or whether or not they've kind of been put back into that referral system. So just knowing that maybe there's a way for us to share some data just about the progress of the referral.
Yeah, I know there's some of the CIT work with the board. We had met with a CIT platform that was built by a former law enforcement officer in Northwest Ohio. And when they put that CIT contact form in, if that individual says I'm receiving services at South Community, when they click South Community and hit submit on that CIT contact form, it's going to a pre-identified point of contact at the treatment provider. The treatment provider is, when they open that email, I think they had the option to say like, yes, they received the email or no, they didn't. So they're not disclosing that they have that treating relationship. They're just acknowledging that the referral was received. So he was kind of, because that was one of the questions, was how is that? And it's just acknowledgement of receipt. It's not saying, yes, I'm treating this individual or no, I'm not. So there may also be opportunity with some of the work that's happening with CIT. I don't want to speak on Kimberly and Jen's behalf, looking at how to extract CIT related data from existing law enforcement software. I know it's probably going to be a pretty large undertaking to make that happen, but that would be opportunity for law enforcement to share some of that data if the individual self-discloses where they receive treatment or where they're going. I'm imagining, Tracy, you may know that's something law enforcement documents now is like, they took them to South Community or individuals said they were engaged with that. If there was a way to bring that CIT contact form data together for other law enforcement to see, that may give them some insight into treatment data, again, based on what was self-reported by the individual, but. Okay, thanks.
Casey's like, I'm done. So moving forward, we will compile all of this information. I'm going to send it to everybody on the steering committee. And we will then have another meeting to discuss what our next steps are moving forward. This is a lot of information. There's a lot to do. And I agree with Mark to just take a small bite. Let's start with something where we can have a goal that's achievable that we can meet and then celebrate, get that buy-in, build the trust with each other, and then continue to move forward in our planning. So I want to thank Stacy, Casey, Mark for joining us today. And does anybody have any final questions, comments, or concerns before we adjourn on time? No? All right. I want to thank you guys. Thank you. Enjoy the rest of your day.
Thanks. Take care.
All right. Thanks, guys. Appreciate it.
I'm not gonna.